Well, thank you very much. Thank you for the opportunity to present our work here today. And I must say it's a privilege to be here on behalf of the Pediatric Surgical Oncology Research Collaborative, otherwise known as PSORC, which is a group of surgical oncologists and research residents from around North America that is working to collaborate on studies such as these. So, unlike hepatoblastoma, which has really enjoyed multiple iterative improvements in management algorithms and treatment recommendations, due in large part to efforts by organizations such as the Children's Oncology Group, undifferentiated embryonal sarcoma of the liver has really remained an orphan disease for which there are very few treatment recommendations published in the literature or even guidelines available. It is an aggressive mesenchymal tumor that typically occurs in patients 6 to 10 years of age. It represents about 10% of all childhood liver cancer, and surgical resection remains the cornerstone for therapy, though over the last few decades there has been improvement in survival with the implementation of multimodal therapies. So the point of our study here today was to describe contemporary management practices, again across North America, to in particular evaluate the impact of neoadjuvant chemotherapy on tumor resectability, and then to ultimately identify patient and tumor factors that impact survival. So this is a retrospective study incorporating data from 17 PSORC member institutions spanning the years 1989 to 2019. We evaluated, of course, patient and tumor characteristics, therapy regimens, and overall and event-free survival. We found 79 patients across those 17 institutions with a median age of 9.8 years and the sex and race distribution shown here. There were 27 patients who were resected upfront prior to any chemotherapy, 48 resected in a delayed fashion, of which 8 patients underwent a primary total hepatectomy with orthotopic liver transplant. And as one would expect, the upfront resection patients tended to be more often pretext 1 or 2 lesions compared to the delayed and transplant cohorts, which of course were higher pretext groups more frequently. In the same vein, patients who were in the delayed resection and transplant categories tended to have more frequent vascular involvement of the tumor, and 5 of the 8 transplant patients presented initially with multifocal tumors. Regarding the impact of neoadjuvant chemotherapy, for the 23 patients for whom we had detailed chemotherapy data, about 1/4 experienced progression of disease while receiving neoadjuvant therapy, compared to roughly half, just over half, who had a minimal response, which we defined as less than a 1/3 change in maximum tumor diameter. The remaining 1/3 roughly had a partial response, termed in this study as a 1/3 to 2/3 decrease in maximum tumor diameter. There were no patients with good response or greater than 2/3 maximum diameter change. In terms of the operations that were performed, the upfront resection patients more frequently underwent segmental resections and hemihepatectomies, while the delayed resection cohort underwent more frequently, as one would expect again, extended hemihepatectomies, trisegmentectomies, and the orthotopic liver transplantations. In terms of completeness of resection, there were 2 patients in the upfront resection group who experienced either an R1 or R2 resection, of course representing either microscopic or gross residual disease, compared to 6 patients in the delayed resection group who had incomplete resections. Almost all the patients received adjuvant chemotherapy, and 8 patients in the entire cohort received adjuvant radiation therapy. In evaluation of univariate hazards ratios for the experience of a postoperative event, which in this study we termed as death, postoperative death, or death during the study period, I should say, relapse or recurrent disease, or secondary malignancy, you can see that there, for most variables, we identified trends that we would expect, although they failed to reach statistical significance. The exception, of course, being here highlighted the completeness of resection. So patients who had incomplete resections, either R1 or R2 resections, had an almost 6 times the likelihood of experiencing a postoperative event compared to the R0 resection cohort. In descriptive Kaplan-Meier survival curves, our cohort had an overall survival of roughly 80% and an event-free survival of just over 70% with a median follow-up of 5 years. And when stratified by completeness of resection, you can see a pretty significant drop-off for those patients with incomplete resections. I think importantly, of the 8 patients who underwent orthotopic liver transplantation, there was 100% event-free and overall survival over a median follow-up of 7.3 years. So to summarize, I think our findings would support the notion that neoadjuvant chemotherapy provides a modest effect and may improve tumor resectability in certain cases. The extent of resection does appear to impact survival, and for patients for whom an R1 or R2 resection is anticipated or highly likely, liver transplant seems to be a good option. So with that, I'd just like to thank all of the partner organizations who participated in this study, and in particular, I'd like to thank Doctors Roshni Desgupta, Rebecca Myers, and Reto Bartscheiger for their guidance throughout the course of this study. I'd be happy to take any questions.
Well, I think, Zach, it shows the importance of a group like PSORC, because to get 79 or however many it was of these extremely rare tumors and to be able to say something about them is important. I was just wondering, I was thinking about the idea of hepatoblastoma and the large tumor with annotation factors, et cetera, and the early thoughts and referrals with respect to liver transplant centers, liver transplanters, liver transplant evaluation. Would it be your suggestion to think the same way for this rare tumor?
In general, yes. I think that a lot of the principles that apply to hepatoblastoma in terms of the preoperative decision-making should apply to undifferentiated embryonal sarcoma as well as many other the liver malignancies we deal with. I do think that when talking about upfront resection, there are some subtleties with respect to UESL that don't apply to hepatoblastoma. In particular, I think it is reasonable to consider up to a trisegmentectomy if you can confidently approach that tumor to achieve negative margins at the upfront operation. I think that's reasonable. If there's a question about the vascular margins, then I think a trial of neoadjuvant chemotherapy and a discussion with the transplant center makes a lot of sense.
Great. Thank you very much.
Thank you.